Dr. Pravin. He's not here, but he has sent a pre-recorded talk. So if you could have the pre-recorded talk. No, it's okay. It's the last session of the day. Yes, we should ask more questions. This needs to have a voice to it. There's a voice to it. Please play the audio as well.
And unfortunately, I'll only be reaching tonight. So Dr. Nidhi, as well as the rest of the speakers of EKLG, as well as members of EKLG, have kindly agreed to me doing the recorded talk. So the topic of my presentation today is going to be about being able to predict the outcomes of endothelial keratoplasty. But before we actually start speaking about the outcomes, I'll take a couple of minutes about why is it important to be able to predict the outcomes of endothelial keratoplasty. So I come from LV Prasad Eye Institute in Hyderabad, and the cornea service at LVPI is called the Shantilal Sangvi Cornea Institute. And we do see a number of different disorders in the clinic. And amongst the disorders that we see in the clinic, on an average, about 150,000 patients in a year. The least common actually are patients who come in with endothelial disease. So, in fact, endothelial disorders forms about 3% of all patients who come into the clinic, whereas ocular surface, infection, inflammation are the majority. So why are we still talking about a model that will predict the outcomes of patients who have surgery for endothelial disorders? The reason is, though they're rare, the number of patients with endothelial disorders that require surgical intervention is very high. Almost everybody requires a surgical intervention. And amongst the approximately 4,000 patients with endothelial disease whom we saw last year, close to 50% of them are those who had post-cataract surgery, corneal edema. Then about 30% were patients who had corneal edema with no known etiology. About 16% were endothelial dystrophy, large majority obviously being Fuchs, or 8% were graft failure. And I was just talking to you about the need for endothelial disorders to be treated surgically. And we just completed about 50,000 corneal transplants somewhere about last year. And of the patients who undergo corneal transplants at our institute, endothelial disorders is the second most common reason why we've done transplants in the last several years. These are 5-year blocks. And in the current data that we have of patients who are undergoing endothelial keratoplasty, EK, which is a combination of DSEC and DMEC, is the most common type of keratoplasty that is being done, which is the reason why it is important to be able to predict the outcome of this surgery. At this point of time, when you speak to a patient about predicting the outcome of surgery, we only are able to quote numbers from small published articles, majority of which actually are not Indianized nor Asianized. A lot of them are eyes from Caucasian data, so it might not be as accurate. Mainly because the distribution of the pathology that we deal with in India and in Asia also is very different from the pathology that we probably will have in other countries. Give me a second. Amma. So, sorry, I'm having a little bit of disturbance in the OR, but so what we did with our data of all our corneal transplants was we took all our data and we put it into a database. Almost 30,000 surgeries went into creating this online database. And we looked at several parameters. And in fact, some of the parameters we looked at was also distance. And interestingly, about half the patients that we deal with have to travel more than 200 kilometers to the hospital. And about half of these patients are located in rural or semi-rural areas. This is probably very different from the Western literature as well as the distribution of patients where access is not so much of a problem and where the type of disease for which endothelial keratoplasties are done are very different as well, the majority being Fuchs. Now, this is important because the ability of patients to follow up is also diminished by distance. And this is shown in this particular graph where it's seen that about half of the patients who undergo surgery at LVP don't follow up at the end of 1 year. This may not be very critical from the point of view of endothelial keratoplasty because you don't have sutures to deal with. But in general, lack of follow-up also means lack of compliance to medication. And it has been shown that not using steroids long term has a much higher risk of rejection in these patients. And this is the reason why follow-up compliance is not that important. So what we did initially is we actually built an AI ML model for predicting the outcomes of keratoplasty, not just endothelial keratoplasty. And what we tried to do here is we tried to see if we can predict which graft is likely not to do well after surgery, who is the most likely to miss a follow-up visit after surgery, where do these people who miss their visits come from, and would also help with pre-surgical decision making. So as part of this model building, we were able to get about a 75% accuracy, the prediction of visual acuity, and we were able to get about an 80% accuracy in being able to predict who would be compliant to follow. We also were able to get very good survival prediction curves, and these were relatively accurate in the first 12 months with about close to 75 to 76% accuracy. What we've done with this is we've converted this into a mobile application, and this will be available for use by physicians across the country, colon transplant surgeons, as a mobile app, and hopefully by the end of the year we'll be able to have this released and available for use. Following on that, we also tried to build a predictive model for endothelial keratoplasty. And here we've tried to predict the post-surgical best-corrected visual acuity and to also to forecast the expected graft survival rate for EK procedures. So we used several different models to actually build this predictive algorithm. I won't go through the details of this, but then the overview of the data set was about 9,400 procedures went into building this data set. And this was around 8,000 patients, and about 3/4 of these procedures were completed in the last 8 years. So it's more recent data. And we also have data going back as long as 18 years because that's when we first started doing DSEC surgery. And following beyond 3 years, the post-op follow-up data was relatively sparse, only about 15%, as you can see in the graph as well. Even distribution between males and females, more of our patients were about 2/3 were patients who paid for their care, about 1/3 were from the lower socioeconomic strata, about 40% urban patients, and like I said earlier, about 55% of our patients resided more than 200 kilometers away from the surgical center. About 3/4 of our patients are over 50 years of age. So the preoperative best-corrected visual acuity, about 74% of patients had very poor vision, that is vision less than 2400, which is very different from what you would see in data from Fuchs patients, because these are mainly post-cataract surgery called edema. And like you see, the top indication, 62% of our cases were because of post-surgical corneal edema, and only 6% were Fuchs dystrophy. Of the types of surgeries, we started doing DMAC from about 2017. So overall, about 78% of our cases are actually DSAEK, 11% DSEK before we used automated tissue prep, and about 11% of them are DMAC overall. But now, since 2018, about 20% of our cases are DMAC annually. Additionally, we had a couple of other surgeries, IOL exchange and cataract surgery being the primary surgeries that were done in conjunction. So the features of the model were we selected demographic, clinical, and surgical features, and a few post-op features as well. So the demographic features are fairly commonly collected by all hospital systems. Clinical features, we picked best corrected visual acuity, the indications for surgery, any comorbid conditions, and any other surgical conditions that were done. For surgical features, we picked the type of surgeon, experience, the diameter of the graft, the donor parameters as well. So when we looked at the number of surgeries that we did based on year, we had about 1,000 endothelial keratoplasties done every year. And with time, you can see that DMEC has become a little more popular, but because of the kind of patients we have, DSEC still is the predominant endothelial keratoplasty we do. The best corrected visual acuity outcomes for DSEC were relatively poor. About a third of patients didn't have improvement in visual acuity as compared to DMEC. That again is because of the very challenging eyes that we do DSEC in. The patients with Fuchs had very good outcomes as expected, whereas the patients with either sort of a conledema or failed PKs didn't have very good outcomes as you would anticipate. So the visual acuity outcome prediction model that we used, where we had only pre-op data, had an accuracy of about 72% in predicting the visual outcome post-surgery. And if you use the first month post-op data, had about 83% accuracy in being able to predict future visual acuity as well. This is the area under the curve, the ROC curves for both models with pre-op as well as pre-op and post-op data. And you can see that the one that has both pre-op and post-op data has a little better accuracy in prediction. And we will also be able to predict the graft survival relatively accurately in about 80%. It is aligned with the prediction of the graft survival with some amount of standard deviation as well. So to summarize, what we had was we found that Fuchs dystrophy followed by post-surgical conedema had the best outcomes as expected. Failed grafts are the indication that had higher poor and very poor outcomes. More than 50% didn't do very well. About 28% of failed grafts showed no improvement in vision. 60% of cases overall showed an improvement in best corrected visual acuity, and about a third remained the same. So about the AI model itself, the pre-op model has about 72% accuracy in predicting post-op visual acuity. The post-op model that includes one visit post-op has about an 83% accuracy and is about 82% accurate in predicting graft survival post-op. The initial results are very encouraging for forecasting and decision making, and you can actually now tell your patient with more confidence how their grafts will do. But in the future, we hope to increase the number of features and also refine the existing features to make it more accurate. And hopefully, this is something that we'll share with all of you in the future as well. Thank you very much for your patience. And sorry again for not being there in person, but hopefully, I'll see you tomorrow at the meeting.